Assalamu alaikum. Lecture 3, Part 1 in Pediatric Surgery will discuss hypertrophic pyloric stenosis. It is an acquired cause of intestinal obstruction. It is not a congenital one, and now we will know that in the next slides. Regarding pylorus, it represents the gastric outlet. What is the incidence of hypertrophic pyloric stenosis? It's about 1 to 4 per 1,000 of live births in white infants. More in male than in female, with a ratio of 4 to 1. It is again an acquired condition. It is not a congenital one. Regarding the etiology of hypertrophic pyloric stenosis, it is yet now is unknown, but there is a risk factor. Again, it's more in male than in female, more in white than in non-white population, more in firstborn infants with positive family history. There is an environmental risk factor, including breastfeeding rather than formula feeding. The breast is a protective rather than formula. Formula is associated with higher risk of pyloric stenosis. Seasonal variability, more in spring than in other seasons. Exposure to the erythromycin, also it could be associated with the higher incidence of pyloric stenosis. About the condition or pathophysiology, there is a hypertrophy of the pyloric muscle. This hypertrophy causing enlargement of the muscle thickness of the pylorus, causing compressing of inner mucosa, submucosa, leading to the stenosis of the canal, stenosis of the lumen, rather than complete obstruction. And this condition is occurred after delivery, means in the neonatal period. Age, it's most likely to occur in 2 to 8 weeks, and other 2 weeks to 2 months, means that age of condition mostly to be diagnosed as this age, 2 weeks to 2 months. The baby complaining from non-bilious, because the obstruction is proximal to the ampulla of vata, means is the vomitus. It represents the gastric juice and gastric content, and the vomiting is a projectile. This because of peristalsis of the stomach against the closed or stenosed pylorus, causing back pressure of this peristalsis to cause a vomiting. So it's forcible projectile vomiting in full-term unit. And this projectile vomiting, it should be differentiated from those with gastroesophageal reflux disease, because at this age, many neonates might complain from gastroesophageal reflux disease, and the vomiting in this case is non-projectile. It is regurgitation-like, effortless vomiting. But in pyloric stenosis is with effort, and it's a projectile. The vomiting might be associated with coffee ground emesis, and the cause of recurrent vomiting, either it's caused esophageal tears. This repeated vomiting with failure to benefit from the feds lead to dehydration, lead to failure to gaining weight, lead to the constipation and decreased urine output. On examination, the baby looks anemic, might associate with jaundice, dehydrated, cachexic, emaciated, or failing to gaining weight. On examination of the abdomen, the visible peristaltic waves of the stomach against stenosed pylorus might be observed on palpation. Pyloric mass might be felt in the right upper abdomen, and this is called olive sign. Investigation, what we have to do for such a baby. The diagnostic investigation to ensure the possibility or ensure the diagnosis of this child has a pyloric stenosis, the golden standard investigation for this case is an ultrasound. And the radiologist will or should show the muscle thickness of the pylorus. It is 4 and or more millimeter for the thickness, and length of the greater than or equal to the 16 millimeter is diagnostic for pyloric stenosis. Regarding ultrasound, again, we have not accept the sonarist that report there is a just dilated stomach, and it's most likely a case of pyloric stenosis because this condition might be associated with pylospasm. The diagnosis of pyloric stenosis by ultrasound should give the thickness and the length of the pyloric muscle. Okay, this is ultrasound finding. The photo on the left shows the thickness, and it's 4 and more, it is diagnostic. On the right side, it indicates the length of the muscle of the pylorus. 16 and more is diagnostic for pyloric stenosis. The other diagnosis or other investigation should be done for the baby with the pyloric stenosis because of the repeated vomiting with loss of acid leading to the electrolyte disturbance and dehydration. So we have to do the blood gas analysis, and this will show the hyponatremic, hypochloremic, metabolic alkalosis. Because of the loss of the gastric juice leads to the hyponatremia, hypokalemia, hypochloremia, beside metabolic alkalosis due to excess loss of acid, beside the dehydration. So renal function is very important to ensure the baby is not in renal failure or impending renal failure. Other evaluative investigation including CBC, because this may associate with anemia due to failure of being benefit from this feeding. This photo show the meal, contrast meal, and the patient with the pyloric stenosis. This will show the dilated stomach, while arrow showing the pyloric canal, stenosed pyloric canal, and little contrast passing into the duodenum. What about the differential diagnosis? Differential diagnosis including medical and surgical. Medical including whatever the cause of the non-bilious vomiting. On the top of the list is gastroesophageal reflux, other is gastroenteritis, increased intracranial pressure also causing repeated vomiting, metabolic disorder, impairment of metabolism, and also might cause repeated non-bilious vomiting. Other surgical or anatomic causing of vomiting, non-bilious vomiting, is the antral web, foregut duplication cyst at the duodenum or at the pyloric region, gastric tumor that cause extrinsic gastric outlet pressure. What about the treatments? The pyloric stenosis, we can abbreviate or shorten the management is by pyloromyotomy after control of the medical instability. So we have to start with resuscitation. The aim of resuscitation to correct the dehydration and electrolyte disturbance and metabolic alkalosis. So the metabolic derangements, which include the metabolic alkalosis, should be corrected by giving the baby normal saline, and hyponatremia corrected also by normal saline, hypochloremia again, and potassium should be corrected by adding a potassium into the giving fluid after ensuring the baby have good renal function. So the given fluid in this case should include the 9% saline with 5% dextrose. This 5% dextrose because of the baby at risk of developing hypoglycemia. And full saline, aim of it to correct the hyponatremia, hypochloremia. We add potassium to the fluid, 20 to 30 milliequivalent per liter kCl. The aim is to correct hypokalemia after ensuring a normal renal function. The aim of the fluid and electrolyte treatment is to reaching or to correct the sodium is above the 130 and the chloride above 100, and the potassium within the normal level, and to correct the metabolic alkalosis is ensured by reaching the bicarbonate level is less than 30 millimole per liter. After correction of these electrolytes, we can, in short, briefing them is potassium within normal range, bicarbonate less than 30, chloride more than 100, and the sodium more than 130. Now we can say the baby is ready for pyloromyotomy or the surgery, which is performed under GA. It's important to introduce NG before in starting with anesthesia because of risk of aspiration during induction because of the dilated stomach. Typically, the incision is performed in the right upper abdominal transverse, and we explore the pylorus out of the abdominal cavity, and then we do the incision throughout the serosa and muscularis only, keeping intact mucosa and submucosa. That's why the surgery or Ramstead surgery called extramucosal pyloromyotomy means cutting or splitting the serosa and muscularis layer and keeping intact serosa, keeping intact mucosa and submucosa. This is the way of splitting of the muscle. After that, the surgery will be completed. The problem on the pyloric stenosis is compressed mucosa and submucosa by hypertrophied muscle. So, splitting of the muscle and serosa, leaving the mucosa and submucosa to take a relief and release the pressure, causing or leaving good lumen of the canal. Complication of this surgery is less than 1% in overall complication. The most important one and serious one is the mucosal perforation that should not be occurred, and investigation or the examination of the mucosa and submucosa after splitting should ensure there is no perforation. Other complications including wound infection, incisional hernia, the site of the laparotomy of the abdomen, prolonged postoperative emesis, and this is a usual condition because of a dilated stomach and inappropriate gastric peristalsis. Incomplete myotomy leading to the persistent vomiting, and duodenal injury again is a part of the perforation. Regarding outcome, as mentioned, is less than 1% overall complication. This is the end of the part 1, lecture 3, that describe hypertrophic pyloric stenosis. Thank you.